We're going to invite the panelists up now, and we'd like to get the cases up as well. We do have a guest panelist to introduce. We've asked Dr. Claudio Cernea from Sao Paulo, Brazil, to be with us on this panel. So welcome, Claudio. Thank you. I think there were many very excellent points made here today, all of which we can expand on significantly, and we'll try to elucidate some key points here through the cases. Let's have the first case here. I think we can go ahead and do that. And we encourage an open mic and discussion here. So if you have any questions about what we're discussing or you think we're crazy, please come up and let us know, okay? This is a 47-year-old woman with no other medical issues, completely healthy, who's been diagnosed with a 2-centimeter papillary thyroid cancer on fine needle aspiration biopsy via ultrasound guidance. During a cervical screening of the lymph nodes by ultrasound, one lymph node at level 4, 1 centimeter in size, with the loss of a fatty hilum and some microcalcifications, was biopsied, and that proved to be papillary thyroid cancer. Again, a very dedicated, mind you, not thyroid ultrasound, but cervical sonography was performed by the surgeon, and no other suspicious lymph nodes were noted on ultrasound. The paratracheal region had no evidence of lymphadenopathy. So we're going to leave this a little bit open-ended with some pointed questions. And the first question would be, what operation do you plan? And of course, being the new member to the group, Dr. Cernea, I would ask you, what operation would you plan for this woman?
Good morning, everyone. For this case, obviously, it starts with a thyroidectomy, a total thyroidectomy in our book. I think that, at least in our experience, when a patient has a proven lateral neck mass and very suspicious, and we always find needle aspiration biopsy, that mass as well, to prove it as a tumor, we address the central neck as well, electively in this particular instance. So we do not favor elective. I don't like the term prophylactic. I rather prefer elective, like in the head and neck literature, oncological literature. But anyway, prophylactic or elective. We don't usually do elective central neck dissection, except for some instances, which are locally advanced tumors, especially with extrathyroidal, gross extrathyroidal extension. Very aggressive histological types. If you have that in advance, it's very unusual to have that from the fine needle aspiration biopsy. And especially this circumstance, because as it was very well demonstrated here, the vast majority of the patients who already have lateral neck metastases, they do have microscopical disease in the central compartment as well. So these are the circumstances when we do the elective neck dissection, central neck dissection as well. Concerning the lateral neck, and this was marvelously presented by John now a few minutes ago, we also do not advise node picking at all. And we, at our service, we do a selective neck dissection, including levels, in this particular case, 2A, 3, 4, and 5, probably only 5B. This would be the operation we would do in this particular patient.
Mark, can we rely on ultrasound to do anything less? More and more surgeons who have a real appreciation for the anatomy are doing, ultrasound. And some have suggested that we can do selective neck dissections based on the ultrasound findings. Would you recommend doing anything less than what Dr. Cernea has already recommended based on ultrasound findings?
Yeah, I mean, it's tempting to do less to avoid potential morbidity, especially to the accessory. But with the current data, there isn't any evidence to suggest that you should not do what Dr. Cernea said. So I actually would advocate for the same thing, doing the total thyroid, the lateral neck 2, 3, 4, and 5B, as well as the paratracheal on that side.
Iran, can you tell me a little bit more about central neck dissection, why there is so much confusion? And I think really at the basis of this confusion is that the operation has not been standardized. And I would probably ask the panel to describe their central neck dissection technique today, and each one would vary just a bit with regard to anatomical boundaries and technique. And also the literature does not come completely clear on what the technique is, whether one side is being dissected versus both, what the extent of nerve manipulation is, nodal yield, and whether it's being done therapeutically or electively/prophylactically. So can you comment on that as some of the inherent weaknesses here, because surgeons cannot agree how to do this operation? And then, by the way, is it enough to do an ipsilateral central neck dissection or bilateral if we're going to do this?
So one of the inherent problems when looking at central lymph node positivity status is that most papers do not separate between microscopic and macroscopic disease. And when reviewing papers, it is very difficult when they give you statistics as there's bilateral, contralateral positive nodes in 25, excess of 25% or more. Is that truly a macroscopic metastatic node, microscopic metastatic node? And it's very difficult to separate those. And I think that's one of the major issues when you look at the retrospective data that comes out. So I don't think there's a good answer. I think definitely I would agree with everyone here that ipsilateral central neck in this scenario is practically a must. But I'm not convinced, in lack of seeing any suspicious lymph nodes contralaterally when I'm doing the total thyroidectomy, that I would go out of my way to dissect that contralateral area. As for the anatomy, I completely agree with you. I think there's a few papers, I think you're an author of one of them, describing anatomically the extent of central lymph node dissection. And one thing I always also point out to our residents, there is a difference when I'm doing a central lymph node dissection on the right side and when I'm doing it on the left side. And I think it is very important to make that separation. So from my standpoint, a central neck dissection starts from around the height of the cricoid cartilage and ends up at the height of the innominate when I'm looking at the superior to inferior dissection, and it goes from carotid to carotid, and it goes down to the prevertebral fascia, and that's my work in space, and that's what I clean out. Obviously, that goes with the prelaryngeal and pretracheal areas as well. Now, if we look at the differences between sides, a lot of it stems from the direction of the recurrent laryngeal nerve as it makes its way to the thyroid cartilage and the cricoid. And on the right side, when we're going more lateral, we're going to find ourselves needing to dissect above and below or anterior posterior to the nerve. On the right side, I always make a point to look for those nodes that are following underneath the carotid sheath, because that's an area of weakness that many times as part of our central neck dissection, lymph nodes are missed. When we look at the left side, as the recurrent laryngeal nerve is more in the tracheoesophageal groove, we're really having a more open space, so to speak, to clean that out without really needing to work necessarily too much above and below the nerve. So those are probably the pointers that I kind of make when I do it.
Claudio, you have a comment, please go ahead.
You pointed out very clearly that you have to separate between elective, and again, I don't use the word prophylactic, elective central compartment neck dissection and therapeutical. And concerning your previous question, I remember to all of you that even in the hands of the most skilled ultrasonographer, I am not one of them, I do not perform my own ultrasonographies, In the presence of the thyroid gland, it's very hard to find microscopic or metastatic disease in the central compartment, at least in the hands of our ultrasonographers. Anyway, if you decide, we always palpate in every thyroidectomy for cancer, we palpate the lymph nodes. And sometimes we found those tiny 2-3 millimeters hard lymph nodes, and we submit them to frozen section. And then, if proven, that's not an elective neck dissection anymore. It's a therapeutic neck dissection already. But having said that, if you are dealing with a unilateral cancer, especially in this case that you have already a lateral metastasis in the central, in the lateral neck proven, we do, I totally agree with you, but we try to preserve at least the tracheoesophageal groove on the contralateral side. In other words, we don't skeletonize completely the recurrent laryngeal nerve on that side. And this has two purposes. Number one, to avoid the frequency of metastasis on that area is very small, at least in our experience. And number two, to try to preserve at least one parathyroid gland on that side. On the other hand, if you do have bilateral disease or bilateral thyroid cancers or isthmus thyroid cancer, then you cannot predict exactly where the disease is going to. Then we advocate a complete central compartment neck dissection, as you already mentioned. I remember to you that we have a wonderful anatomical paper published last year in Head and Neck. The first author is Professor Marcos Tavares from our institution. And he did an anatomical study in 30 cadavers and harvesting exactly the levels that he mentioned of the central compartment neck, including the upper portion of the thymus. And interestingly enough, there were 2 to 32 lymph nodes, but there were also parathyroid glands in 14 of the 30 cadavers. Most of them had just one. Some of them, several of them, had 2. 2 of them had 3, and one of the dissections had 4 parathyroid glands in exactly that anatomical area. So I totally agree that doing a very, very extensive elective bilateral central neck dissection may be very dangerous for the parathyroid glands.
John, if this patient didn't have a lateral neck node that was positive, would they get a central neck in your practice? And should we be worried about microscopic disease that we otherwise wouldn't know about unless we harvested these lymph nodes?
Yeah, that's a very good point. So, in essence, you'd come back to what was previously said, maybe and what if, 1, 2, 3. I think this is a 47-year-old lady. She hasn't got too many other risk factors. It's a small tumor. In the absence of lateral neck disease, I would not do a full central neck dissection. There's one point I'd quite like to make, and I totally agree with you about the recurrent laryngeal nerve, is that obviously on the left side of the neck, the nerve is 45 degrees to the midline because it's coming back into the neck from around the arch, the 6th arch. On the right side, it's 45 degrees to the midline, and then it's 45 degrees like that because it's coming around the 4th arch. Therefore, you come on it sooner, and you hit it low down laterally. And you have to be very, very conscious when you're doing a level 6 neck dissection on that side. There's another point, actually. In 2011, I wrote a paper in Clinical Oncology where I suggested that actually, and sometimes I regret this because we've got more levels than a railway line sometimes, but you can divide level 6 into 2 areas, level 6A and 6B. And if you take the recurrent laryngeal nerves like that, 6A is medial to the nerve. It's an easy area, and that's where we are. You don't have to dissect the nerve, and almost a lot of the time, I'm doing a 6A bit of a dissection because I'm doing a total thyroidectomy. It's when you go lateral to the nerve, you're under the nerve, you're mobilizing the nerve, you're coming lateral to the nerve, to the carotid sheath. That's when you start to get more complications, I think. But in essence, in answer to your question, Ralph, This lady, I would not do a central compartment neck dissection on, and I'd monitor her thyroglobulin.
Very good. In the sake of time, we have about 20 minutes. I'm going to move along, but just this one case alone can produce a number of questions. We can stay on this one just alone, but let's keep moving forward. 35-year-old woman, 2.5 centimeter right thyroid lobe papillary thyroid cancer on ultrasound. And the preoperative ultrasound shows a left lateral level 3 and 4 lymph node positive on fine needle aspiration biopsy. There is a right level 4/6 inaccessible node for FNA. And many of you have been challenged by these findings and trying to determine what to do with this node that may not be able to be confirmed to be papillary thyroid cancer, right side, common carotid artery, internal jugular vein, and this lymph node here. Now mind you, this is a right-sided papillary thyroid cancer. There are already left lateral neck nodes that are positive. The central neck looks okay on ultrasound, but there's this right isolated lymph node that's sort of in what I described as no man's or no person's territory. Really, it's that border. So what do you do with this lymph node? John, how do you approach this patient? What procedure are you going to do for this young woman? She just had a newborn, by the way, and would like to hold the baby shortly thereafter surgery.
She's how young?
35.
35, okay.
She doesn't want a bilateral lateral neck dissection. She wants minimalist surgery here. What do you tell her?
Okay, and all the root, you always say a bit more information. Everything else is all right, thyroid function, TSH?
Yeah, she's otherwise completely healthy.
Okay. Well, she's got disease in the left side of her neck, which means she's likely to have disease in the central compartment. So she's going to get a left selective, a total thyroidectomy with a central compartment, and then I'm going to concentrate on your suspicious area. I'm going to inspect it, because the best time to do something is when you're there, so get the most information when you're there. I'm going to go hunting around those areas of consternation. If I find anything, then I'm going to send it for a frozen section. And if I don't find anything, and I don't find anything to frozen section, rather than routinely dissect and violate a zone, I'd be very happy to leave the zone, monitor the thyroglobulin, so that if I have to go back, I'm going back into virgin territory.
That makes absolute sense, and I think that's a very good point. You're either going to do the operation in that region or you don't, because if you had to go back, it's much easier, and that's to your point, not going in and just doing some berry picking. So you go ahead, you do find this lymph node, and it's just behind the carotid because you've done a right paratracheal dissection as part of your central neck dissection, which of course, by the ATA statement, always includes the prelaryngeal, pretracheal, and at least one paratracheal compartment, but this is bilateral. Remember, there's right-sided primary, left lateral neck. And so that node is positive. You send it for frozen. It's papillary thyroid cancer. What do you do, John? Do you do a formal lateral neck? Your ultrasound didn't show anything else. This lady wants a return to function. She's heard and gone on the internet the horror stories of bilateral neck dissection and trying to recover from that. She's interested in getting on with her life.
Well, the neck incision isn't going to be any bigger.
Right.
You're there. It's so easy to do 2, 3, and 4 and complete. And the node is high, so as we've already heard, level 5 is unlikely to be involved. So in that situation, I'd dissect.
Anybody else? Claudio, do you have any comments?
Yeah, I have a comment. This patient clearly needs a bilateral, lateral, and bilateral central compartment. That's very clear to us. And the incision we use is a 2/3 neck incision of the circumference of the neck. And we plan, in these cases, to do, like Dr. Shah mentioned yesterday, an incision a little bit higher than the normal Cochran incision, because this gives a much better access to the higher part. But I would like to highlight that we would order, excuse me, in this particular patient, a comprehensive cross-sectional study in addition to the ultrasound, because it's not common, but it's not so unusual, these patients to develop retropharyngeal lymph node metastasis, as well as true level 7 metastasis. And Dr. Heller, who is going to be my co-moderator in the video panel on thyroid technique tomorrow, has a very, very intelligent phrase. He says, "I don't like to be surprised in the surgery." So as much information as I can get, and it's impossible to get this kind of information just from the ultrasound imaging, I would like to have beforehand with a cross-sectional study. In our department, usually a CT scan with contrast. CT scan without contrast is useless, or eventually a good MRI.
I think those are all good points. You have to do what you're most comfortable with in your practice. So if you do ultrasound as a surgeon and you feel very comfortable with the analysis of the neck, mind you that you're not going to see retropharyngeal, parapharyngeal, or mediastinal nodes, then that works for you, and the ATA says that that may be enough. But in certainly selected cases, we're talking not about advanced disease, but even if you have multiple lymph nodes and you feel that CT is better in your institution, even with the iodinated contrast, because otherwise you wouldn't utilize it, it's almost worthless, then it's important to do to give you a map, because obviously, as Dr. Watkinson said, you want to get it right the first time and you want to take care of all that disease. So if that means going ahead and doing the CT, by all means. Remember, the radioactive iodine is adjuvant, and even in these settings, the only thing it may do, and it probably does, is improve the specificity of follow-up testing with serum thyroglobulin, not necessarily decrease risk of recurrence or improve survival. So I think whatever you need to do to feel comfortable about your extent of dissection is important. Well, this is the nice thing about now having done this for many years and tailoring treatment, and I think we need to consider tailoring treatment as to what our patients would like to do. I'm still unsure as to what to do with that node that is retrocarotid, that either is part of the central compartment or lateral compartment. Obviously, there's no magic dividing line, but in this lady, we elected to not do the right lateral neck dissection, and I felt very, very comfortable with that. She had a 2.5 centimeter right thyroid lobe cancer, left lateral neck levels 3 and 4, 3 out of 41 positive, nothing being greater than a centimeter. Left central, 0 out of 10, remarkably, talking about all the skip areas. Right central, 6 out of 13, and that lymph node actually only had a 4 millimeter focus of papillary thyroid cancer. So I think we have to listen to our patients. We have to tailor the treatment. This patient recovered, went home the next day from the hospital without a drain, and was picking up her baby by the end of the week again. And so we'll follow this patient closely with serial ultrasounds and thyroglobulin levels and see what manifests in the right lateral.
Ralph, may I
Yes.
ask you a question about this case? Where was the location, the situation of the cancer concerning the lobe? It was in the superior thyroid pole, or in the body, or in the inferior thyroid pole?
Yeah, great point. So we always worry a little bit more about these unpredictable behaviors in superior pole cancers. And this is one where I had to actually mobilize the external branch of the superior laryngeal nerve off of the cancer, very top part of the superior pole. So a little bit more of a wild card, as you suggest, in its behavior. And a nice study published by our presented by our Korean colleagues yesterday in a proffered paper session really elucidated this more of a wild card or an unpredictable behavior. I'm going to leave this one here for Dr. Heffitz.
All right, so we'll move straight on. So this is a 40-year-old woman tennis player, 1 year following total thyroidectomy and radioactive ion ablation therapy for 3 centimeter papillary. With extension beyond the tumor capsule, the thyroglobulin was too non-stimulated. And the ultrasound shows, a routine ultrasound shows multiple 1 centimeter ipsilateral central compartment neck nodes, which were positive on FNA. And then there was, again, this 5 millimeter level 3 ipsilateral retrojugular lymph node, which was somewhat suspicious. I think we have a picture of it. Mark, can you tell us what you see?
I see a small, semi-suspicious node where that arrow is pointing.
Right, exactly.
I love that arrow.
Right.
Love the
Wait,
arrow.
no, I was going to go back. Ooh. No, I'm going back, wait. I thought we have a Doppler image, but we don't. So that node was, yes, there is a Doppler. Anything else that you want to tell us? And then I'll say what our sonographers described, but is it suspicious? Does it
Yeah,
look
it's
suspicious?
suspicious. I
according-
think, there's a hypervascular area to it. I think that might have been a small microcalcification I couldn't see on the prior image, but it's a pretty small node.
Right. And again, this was described as a suspicious lymph node with microcalcifications, and that couldn't be FN8 because of its position. And then we have a patient with a few lymph nodes in the paratracheal region, ipsilateral paratracheal region, and one little suspicious node retrojugular, again, in the area somewhere between the lateral and the paratracheal region. Eran, what would you do?
Well, she's 1 year out of her total
1 year post-op.
thyroidectomy. So I think I would at first address ipsilateral central neck, where the lymph nodes are known to be positive. At that time, would examine the retrojugular node as well, and send that for frozen section. And depending on the results, decide if to extend the surgery on that side. I would not address the contralateral neck at this point in time.
The contralateral central compartment.
Unilateral central.
Right. Does everybody agree? Claudio, do you agree with unilateral central compartment? In
I think
case
we
of-
need more information. Excuse me, Avi. I think we need some more information here to make a correct judgment. For instance, who was the surgeon who operated in the first operation? With all the respect, if this lady was operated by an experienced head and neck surgeon or endocrine surgeon, I think the central compartment may be a nightmare, because probably the recurrent nerve was dissected. I don't know if down there, probably not down there, but it's a different operation if performed by an inexperienced non-specialist surgeon, as is sometimes the case. I know you're going to say, just a sec, hold on. We have to have some movement here, some discussion, isn't it? So it's otherwise too slow. More than that, I'll strive to get the surgical report on the first operation. I operated last week a lady, exactly in this situation, when the surgeon said, central compartment neck dissection performed. 2 lymph nodes, only 2 lymph nodes. And in the reoperation, obviously, there was no fibrosis. The surgeon was not a specialist. Concerning your question on how would I approach if this lateral node is quite suspicious, I would create an access, prepare the patient, obviously, for a lateral neck as well, a slightly longer incision, including the previous scar. But before the operation, I would inject with charcoal. And I think this is very useful, not me, the ultrasonographer. And it's very, very handy to localize in the reoperative scenario those very, very tiny lymph nodes, especially if they are ipsilateral to the operated site. So we've been doing that. We did that in that lady that we operated last week, and it helped a lot. So we do a backdoor approach, including levels 2, 3, 4 already, and 5. If it's proven positive, it's probably positive. And then we progress the operation through the backdoor approach to the central compartment, find the recurrent nerve inferiorly, where it was not operated probably, and then we proceed with the central compartment, unilateral central compartment in this particular instance.
Unilateral, you said. John, do you agree with unilateral?
Well, I agree with unilateral as long
Good.
as the disease isn't as well on the other side. So if you're describing multiple recurrence in one thyroid bed, are you? Is that
Yes.
Right. Right. Okay. So what would I do? You mentioned the thyroglobulin was unstimulated. I wouldn't repeat it. I don't think it matters now. This patient's got recurrent cancer. She's young and she needs an operation. I'm always in favor of staging operations, particularly when there are risks involved. So I would do one side and I'd clear the disease. The 5 millimeter retrojugular node could be a bit of a red herring. It's suspicious, but a lot of 5 millimeter, you're on the borderline here. And, to go in there and just take that node out, well, you're going to have to do something else, maybe, if if it is positive, I would much rather do one side, ipsilateral neck, and then follow the patient up, measure the serum thyroglobulin, stimulate it if you have to. And of course, the issue then is, has she had radioiodine or not? And if she hasn't, then she might be a candidate for low-dose radioactive iodine. And as I mentioned in my talk, 5 millimeter isolated nodes in difficult areas. This is Chassenak's triangle territory. You can keep an eye on them, and then you can go back in a year or so. But don't try and rush things and do everything in one go, because that's when you get yourselves into trouble sometimes.
So-
Can I make a
yes,
statement?
Ralph,
Can
yes.
we all agree here on this panel that in this, whether it is persistent disease, as Claudio has intimated, or whether it's recurrent disease, that in the absence of contralateral paratracheal disease on ultrasound, the thyroid is no longer there, that it's sufficient to only treat that paratracheal compartment. There's no reason whatsoever to put this patient at risk for bilateral surgery. I don't think there's any question. Let's make sure that we all agree and the audience understands that.
There is consensus. All right, I think in the sake of time, we'll move to, you want to move to the big case?
Yeah, go ahead.
Go ahead.
Okay, so we'll skip one case. And this is a 34-year-old man with the papillary carcinoma on the right side, 2 centimeter, with bulky adenopathy, positive on FNA. So 2 centimeter bulky adenopathy, no evidence of disease at level 5. Ipsilateral. Ipsilateral, yes. The contralateral side is negative. And this is the CT scan, and we can see the bulky adenopathy compressing the jugular vein. And this is the kind of lymph node that this patient had. And this is not the issue here. The issue is the central neck, and the issue is level 5. And let's start with you, Claudio. You see these multiple lymph nodes gathered at level 2 mainly. Level 5 was completely negative. Paratracheal region was completely negative. What would you do?
I would do exactly what he did.
Sorry?
Lateral neck. You did the lateral neck here.
Yeah,
And you're asking about the central compartment?
and level 5.
In this particular, with this bulky lymphadenopathy, I think it's advisable to include level 5B at least in this specimen. So I would definitely do level, and I didn't get it exactly from the imaging. The lymph node was in level 2?
The lymph node is level 2, yeah. This is the lymph node.
It's 2A or 2B?
Yeah.
Yeah, with such a bulky lymphadenopathy in level 2A, I probably include level 2B as well, because
Okay.
I don't want to reoperate on that area. And eventually, if you have a large lymph node like that in level 2A, it's possible to have level 2B microscopical disease as well. And regarding the central compartment, of course, as I mentioned already, I would include the central compartment for sure, as a total thyroidectomy, of course.
What about the contralateral central compartment?
Excuse me?
The contralateral central compartment.
No, I would not address. I understand there is only unilateral disease here, and this is a unilateral tumor. Is that right?
Right.
No bilateral tumors.
No.
No isthmus tumors.
No.
Tumors. I would do, as I mentioned previously, yes, the unilateral elective, in this case, elective central compartment neck dissection.
Yes, Ralph.
I just wanted to ask John to really emphasize the importance in here, especially when you're talking about level 5B. John, can you tell us and the audience why it's so important, especially in thyroid cancer, to be down in that area on the left side around the thoracic duct, along the internal jugular vein, even at the confluence of the subclavian vein? Why we don't really have, and Mike Tuttle, please don't get mad at me here, I think you would agree, really good adjuvant therapy, right? So the onus is on you as a surgeon to get rid of that disease. So can you tell us why?
Well, there's an area in the neck where the scalenus anterior meets longus colli, and the lower border is the subclavian vein, and it's Chassenak's triangle. The contents of that triangle are the inferior thyroid artery with its branches, vertebral artery, you've got the ansa subclavia, you've got the extending occipital artery, and it's where the confluence of the cervical lymph nodes coming down meets the thoracic duct, and where you get these nodes, nodal masses, particularly, remember the rising sun sign, when cancers coming up from the chest. So it's a big zonal area. Now, if you do a neck dissection and it's radical, and you take the vein, the jugular, you're right on that zone. But if you're leaving the sternomastoid behind, you're leaving not only the front door shut, but then you get to the kitchen door, and that's shut as well. And unless you open those doors, you do not see that area. And in my hands, my experience, the commonest area for neck recurrence following surgery for thyroid cancer a couple of years ago is in this area. So when you're there, just pull the jugular laterally and go in there, and it'll just peel out.
An announcement.
I'm sure this panel can go another 4 hours, but we have to end.